Well, what's up, everybody? MIke Verkest, Dr. Jeff Jarvis, Dr. Peter Antevy, hanging out on a very, turns out to be stressful Wednesday night for some reason all of a sudden.
Mike, how you doing, man?
I'm not doing very good, actually. Thank you for asking.
Well, we know why you're not. So you are the one driving this technical show, and we've had a couple of technical difficulties. So you've been the one stressing out about it. Dr. Antevy, Peter and I are just sit back. We're having a drink, and we're not stressing very much. How are you doing, Peter?
Oh, he's muted.
All right, folks, if on your bingo card you had unmute your phone, Dr. Antevy, drink up.
Okay, here we go.
I think that's good. Let's do that.
There we go. All right. Welcome to the show. So so what do we think here? We switched to this new platform with the idea.
Great platform.
Yeah, it's a great platform. And the idea is that not only will we go live on Facebook, we'll go live on the tubes of you, on the Twitter sphere, on the ends that are linked, and on the webs themselves.
That's right. That's right.
And
that's pretty bold.
Yeah, and I was just going to say, and tonight apparently, not Facebook. First, first it said it won't go to Facebook, and then it did go to Facebook, and now we're not on Facebook.
I was going to ask. So we are not on Facebook.
I don't think so.
Okay.
But we are on Twitter. We are on YouTube. We're on everything else. live.flightbridged.com. We're on all those places except Facebook.
Well, this is a bit of a challenge. I was wondering what the best way, perhaps we can, do you have someone who might be able to take that episode 38 icon, throw it back up in a new post on Facebook and say, hey guys, technical difficulties, feel free to watch it on any of these channels. But if you want to chat with us, do it here. You think that would work? And then we can just follow it independently?
Yeah, I mean, essentially that's what we can do. So we're live on YouTube. So let me just see if I can share that. So I will copy the link. You guys should talk and let me do this crap.
Well,
outstanding.
I'll tell you what, I'll share a snafu that happened to me yesterday. Another Zoom snafu. So we're holding a webinar where I kind of moved the entire company to Zoom, right? Because we hated GoToMeeting. Yeah. And we had about 300 and some odd registrants for this webinar. And of course, we had only signed up for the pro account, which is only 100 people. So we're getting all these dings, and no one can come in past 100. So I'm trying to upload the thing, update it so I can pay for more. You can't do it once it starts. You're done.
Oh.
So imagine how many people are pissed at that. So
I imagine. So you probably had what, 3,000-4,000 people wanting to hear what you had to say, and
then I woke up. Yes.
Oh, I don't know, man. I think you'd pull that. That's well, I'm sorry to hear that. That's classic Zoom.
Yeah.
So that was the pro. What you really needed was that I'm serious pro level.
You gotta love it. Zoom has this great freemium model where it seems free, and then all of a sudden, if you're a single person trying to make a meeting with more than one person, you got to pay. But you could use Zoom free for life if it's only a one-on-one meeting for 40 minutes.
Yeah, and who does that?
Right, exactly. So
awesome. Well, I'll tell you what, Mikey, while you were doing that, we have a pediatrician with us. So why don't we, and you know what we normally do at this point, the way these podcasts typically work is, first off, we got to hit the important stuff. What are we drinking?
Yeah.
And then there's some sort of jackassery, usually involving the situation. So let's get the important stuff out of the way.
Okay.
What are you drinking, Peter?
So I have here something called Slow and Low. It's an 84 proof. It's an old fashioned. And it is, unfortunately, we've Instacarted a lot of this to my house. And when the lady comes up and she hands me a bag with 5 of these bottles, she looks at me and I said, yes, it's COVID. And I just take it.
Exactly.
so you can Instacart the booze?
Yeah, exactly. Yeah, you can Instacart that. Yeah. She asked for ID. I'm like, look at the hair. She's like, I need the ID.
Yeah, I do that too. Look at the lack of hair. So what is the difference between a slow and low and a typical old fashioned?
Well, the slow and low, it kind of blends everything in together. So, I mean, listen, I have plenty of bourbon here, and I have the bitters, and I have the simple sugar. But this kind of puts it all in one bottle for you. It's the lazy man's old fashioned.
Oh, okay. All right.
Comes ready to go.
Comes ready to go. And one of my favorite people in the world, Ryan Gentilcore, who's a captain at Fort Lauderdale Fire Rescue. He works with me as well at Antevy. He bought me the bottle, and I mean, everything else sits in my closet, in my cabinet, and that thing just gets used up.
Nice. Yeah. Well, so I'm an old fashioned man myself, love me an old fashioned. And I saw some things on Facebook that they're marketing I don't know whether they call it proof or something else, but it's the old fashioned mix.
Yeah.
Minus the bourbon. So you can add whatever bourbon you want. And I put some hints out to my beloved wife that it might be interesting if that showed up around Christmas time. Well, in the meantime, I'm drinking an old fashioned too.
Hey,
difference.
All right.
The only difference is that it doesn't have bitters. It doesn't have simple sugar, simple syrup. There's no cherry, no orange. Okay, so it's just straight bourbon.
I was going to say, what do we got going? It's a vodka water, hold the water.
Exactly. Mikey, what are you drinking?
I've got myself a little George T. Stagg here in my little Glencairn glass. It's delicious. Hard to find. Eric got this for my birthday for me back in May, and I've been nursing on that bottle. I still got half of it left, but it's a hard one to find. So every once in a while I'll have a little taste.
Have I mentioned lately what a great guy Eric is?
You don't need to hear that.
So let's now move on to phase 2, segment 2 of the pod. We have got to talk about the situation.
Yeah.
So I mentioned this. I was in the emergency department today, and it was COVID as far as the eye can see.
Yeah.
So our system decided that we got our X number of doses of, I want to see if I can get this right, bamlanivimab. Did I get it?
Pretty close. Yeah, it's pretty good.
So that, in case everybody is not, I can't imagine everybody is not familiar with this drug. It is a monoclonal antibody to COVID. And in the literature that has been published, it shows that it decreases hospitalizations and return ER visits by a bit.
6% or so? Yeah.
It's something like that. I mean, it's under 10, but it's more than 1. It is not earth shaking, but you know what? Not bad. It's something we can do. They're antibodies, so the adverse events pretty low, and it could help. You can't give it to people who are actually sick. It's an outpatient drug. Don't give it as an inpatient. Don't give it if they're on oxygen. But yeah, if it can keep them out of my ER, not that I'm not happy to see them, but I think they would prefer to be out of my ER. So we're given that, but we're doing it in the emergency department, and it's it is about a 3 to 4 hour process.
Oh wow!
You have to have a COVID test within the last 7 days. So if you come in, you say you had a COVID test, but it was at an outside facility, we got to get a new COVID test. So that takes about an hour. Takes about an hour takes probably 20, 30 minutes to go through the consent process, about an hour to get it from the pharmacy, an hour to give it, and then we have to keep them there for an hour after to watch them. Wow. So doing that, lots of COVID testing. So what definitely is coming back up. What do you see?
Well, we actually are seeing them come back up. In Florida at the peak, we had 10,000 hospitalizations in the state. We're now at 4,400. And so we've been steady for the last, several months. We're finally starting to see it peak a little bit. But the medication you're talking about, interestingly enough, what we do at our shop, on the adult side, of course, is that we are now sending people home with risk factors who we would have admitted a few months ago.
Yeah.
With a pulse ox, it links into our app, our hospital app. They get called on days 1, 3, 5, and 7, and so forth. And then if their test comes back positive, we will call them back in. We have some risks, in other words, if you're over 65, you get it. If you're 55 and over with risk factors, you get it. If you have asthma, diabetes, you get it. And we designated one of our hospitals as the place that you can go get this drug. And I'm surprised that we've only been doing it for about a week or so. I thought this would fill up the emergency department, or at least that one unit. And I've heard people around the country are now opening up centers because if the general public knows about this, you would think that everybody would want it, right? This is what the president got when he got sick. So I think it's going to build momentum, and I think it's going to clog up a lot of ERs unless they start to do the right thing.
So are we sure? I don't think that is what he got. I thought he got the polyclonal antibody.
Yeah, the Regeneron, right.
Okay.
Right. So, and we have both now at our place. So we have Regeneron or the Lilly product, which is what you talked about.
Okay. Yeah, definitely
same
Lilly.
concept. Yeah.
So we have, I'm just pulling up the Texas data here, and it looks like we had just under 11,000 cases today in Texas. I think I haven't seen the Williamson County numbers today because I was in the ER. But it looks like my guess is it's going to be about what it was yesterday, mid 200s for the county. And it looks like Texas had 273 deaths today.
Wow.
So,
yeah, we're at almost the 10,000 range here in the state, and we're kind of moving to averages of about 8,000 to 10,000 a day in our state.
Wow.
Well, let's talk some pediatric stuff. So I'm on a group chat with all of my emergency medicine colleagues in my system, and they sent me something. I can't share it with you, but I just want to give you the general concept. And they were looking at a children's hospital somewhere here in Texas that was looking at weekly viral panels. So kid comes in, looks like a viral illness. You order a respiratory viral panel, and here's the distribution of the critters that you find. And, the majority of them, enterovirus or rhinovirus or influenza, coronavirus, like the normal coronavirus, not this dude. And you see a seasonal spike up, down, up, and then we hit COVID time. And right before COVID, you see this big spike right about where we expect. COVID hits, and these viruses went to nothing. I mean, just disappeared. And it's really interesting. And there are probably a couple things that you could interpret from that. But one is we shut schools down. Now, whether that's a good thing or a bad thing for the kids is not really the point here, because it happened and we're looking at the impact. So they're not spreading their little viruses in their little educational petri dishes. Yeah. The other thing is nobody showed up in our ERs, and
and that happened here. And what's fascinating, in New York City during the height of the pandemic, there was a great picture, I believe it was in the New York Times, and it says, where have all the children gone? And it was a picture of an ER doctor sitting on an empty bed and basically exposing the fact that the pediatric ED volumes went to nothing. Nurses were being told, sorry, don't come to work. And so the exact opposite of what was happening on the adult side, we were seeing on the pediatric side. So I think it's a combination of what you said and the fact that people were just, not showing up. And I'm sure all of you have seen this, but the amount of people, I've never gotten so many medical control phone calls that I've gotten in the last several months because of people who don't want to go to the hospital. They're having MIs, they're having flagrant STEMI. And the guy's like, I'm not going anywhere. COPDers, sitting at 65, 70%. They don't want to go anywhere. So it's been pretty crazy.
Amazing stuff. Yeah. Well, let's see. We were talking, and what we're doing, guys, again, for this episode is we have some pre-recorded content that we're going to do. We bring back Dr. Aaron Lincoln, who's going to do an oral board for us. And you might imagine, one, we bring Peter on because he's our friend and he's fun to talk to, but we also bring him on for his pediatric expertise. And so you might guess that we're going to talk about a pediatric case. Oh, hell, I guess we already let it out of the bag. We're talking about pediatric intubation risk factors. So let me try to sort of make a segue here. What are y'all doing now? You get kids in, and let's just say, not neonates, children to pre-adolescent. So, say 3 to 10, somewhere in that range. And they come in with COVID. And are y'all trying to intubate early, trying not to intubate early, doing anything different than you would have normally done? How are you managing them?
Well, to be quite honest, the sickest kids we're seeing are the MISC kids. So there's the post-COVID sequela of COVID. So the kids who are ending up in the ICU are not the currently COVID ill kids. It's those kids who are weeks past, and they're typically older, just like the New England Journal paper that had it showed 99 children from the New York City area who all had MISC, and they were all 6 or older who were the sickest. So the older you are post-COVID, the highest risk you are of having severe hypotension requiring pressors, intubation, and so forth, and so ECMO. And so we have seen that, and our ICUs have the post-COVID patients in them even today.
Wow.
Yeah.
So you called this something, and I think I know what you're talking about. I think about this pseudo Kawasaki sort of thing.
Yep.
Is that what you're talking about?
Yeah, it's MISC, multi-system inflammatory syndrome of children. Now they have an MISA because they've seen it in adults. Okay. And essentially it's an inflammatory process that occurs in the small blood vessels everywhere. And so Kawasaki's, there's one big difference, is that Kawasaki is also an inflammatory disease of the small blood vessels. So you had the red eyes, but there was no drainage. Same thing, right? You had the red lips and the red tongue. Okay. Even at if you look at the tip of the penis or the urethra, it was red because basically small blood vessels. That's where you had the inflammation. The danger of Kawasaki's, of course, is that it caused inflammation of the coronary arteries. It caused aneurysms. But if you gave IVIG within 10 days of the diagnosis, then you spared the kid of a cardiac issue for the rest of his life and a lawsuit.
Yeah. So now for that, Peter, you're talking, that's our traditional approach to Kawasaki's. Correct. Does that have any benefit in this other?
Absolutely. So we would give aspirin and IVIG to children with Kawasaki. So they get admitted to the hospital, they get the echo, they be on aspirin, high dose aspirin, they get IVIG 1 or 2 doses, and everything would just then resolve and they would do great. With MISC, it's the same treatment. However, we're noticing a significant number of these kids end up in the ICU, which we never saw with Kawasaki. I mean, I could think of in 20 years, very few children, if ever, with Kawasaki ended up in the ICU. This is the same type of dilemma, except that add on, a lot of badness. And that article in the New England Journal showed that a very high percentage of these children who were admitted go to the ICU, and a very large percentage of them needed, pressors, and a few of them needed ECMO. Very few of them were hypoxic. Very few of them were tachypnic. It's not a lung disease by the time you get to these kids, but they do have fever, and they're tachypnic because of the fact that they're having a metabolic issue. It has nothing to do with their lungs anymore. So what I would tell everyone here who's a pre-hospital person is there's no time to wait for the hospital to give fluids. There's no time to wait for the hospital to give pressors. And when you see these kids, they'll have fever, they'll look sick as shit, they'll be hypotensive, tachycardic, tachypnic. Give them fluids, give them pressors, or maybe even push dose pressors. And if you have a steroid, give them the steroid. And so those are my recommendations, but it's kind of still basic shock care, if you will. Yeah. But you guys probably see the same thing. I know Jeff and Mike, where you're located. My experience is when you're 7 to 10 minutes away from a hospital, in EMS we say, well, they're more equipped. Yeah. But we're not more equipped. We're slow as shit to get pressures on board or fluid. So we ought to be doing that in EMS, and that's my big push here.
Yeah. So let's ask Mike. Mike, let me get a rough estimate, if you will. Now, if you need to pull up a calculator and do some math here, it's okay. You can do it.
Oh God.
What is the average number, or you can give me median if you want. Either way, what is the average number of patients your paramedics are taking care of at a time? Now, again, if you need to give it to me in standard deviation.
Hold on a sec. This might be a case where like the forest plot would come in handy. Because I do like a good forest plot.
Almost as good as a waterfall plot. Yep.
Yeah. I would say one.
One. Yeah. Okay.
Yeah.
In my ER today,
was I right?
That sounds good. I think I did. I think Peter and I are actually going to publish a paper on this using ESO data and 7 million calls, and we're going to look and calculate the average number of patients per run, and I think we're going to get pretty close to.
It might be
one.
Yeah.
Yeah. So you can do things really rapidly for those patients. Now, in my ER today, we were getting our butts slammed. Early on, I was the only doc. We went from about 4 patients in the ER to about 24 patients in the ER. If you use a loose definition of the ER to include the waiting room, in about 45 minutes, you can't keep up with that. My nurses can't keep up with that.
How many patients you have boarded, if any, Jeff? You have patients who are sitting there?
Would you believe? So this is fascinating. We had a gentleman. I can't really say how he was sick because it's a little too early, but he was sick and needed to go back to a hospital where he had his initial procedure. They were closed. They never close. They were closed because they were not just full of their normal full people, but they were also full with COVID patients. So they couldn't take that patient. And that is just unheard of. They always take their patients. Couldn't do it. We had the 2 people getting the Bama Ding Ding antibody treatment. And then, just your run of the mill, needs a surgery for the normal thing. So it's sort of interesting. Full. So yeah. And our nurses were taking a while to get stuff to the patients because there's only so much you can ask of them.
Yeah.
Right. So they have more than 1 patient at a time, you're saying?
Yes. So your point, Peter, is absolutely right. We have them. We can get the therapy for them much faster. That's why I twitch when I hear, well, we didn't do it because we're just around the corner.
That's right. Right. Well, you know what I mean, and even worse, I manage a private ambulance service, and like I've been doing it for a while now, but in the first year I got there, I would get a call from my medics in the ambulance bay. They were doing an interfacility, and they just left the emergency department. They're in the bay, and they call me, and they say, "Doc, we got a 65-year-old patient. She's septic. She's hypotensive." I'm like, "Didn't you just leave an emergency department?" They said, "Yes." And I said, "Well, why didn't you say that in the emergency department?" "Well, because we didn't want to, interact with this doctor guy over there." And so it's very interesting how the whole concept of we do things really well, and sometimes even better than the hospital, really has to be, you have to just keep informing them. And now we're at the point where I think most of the people in our area are so convinced of that, thank God, that they actually now are staying on scene. They're doing what's right for the patient. We're doing DSI thanks to you, which is a very slow moving thing, right?
Yeah.
We'll get into later today.
Hurry up and slow down.
Hurry up and slow down. And once you have that concept of hurry up and slow down, guess what? The patient gets better care, and you become a better, healthcare professional at the end of the day. So, yeah.
Our friend, Dr. Veer Vitellani at MedStar in Fort Worth, he refers to exactly that thing as SAD, which I just love. He calls it the sudden ambulance death syndrome. So it's awesome. If you ever get a chance to hear his, and I know y'all have, but if anyone listening gets a chance to hear him talk about it, you definitely should do that. Well, I'll tell you what, why don't we transition here? And I think it is about time. What we're going to do here is run 2 segments of pre-recorded video. One is with me talking to Dr. Aaron Lincoln about a pediatric case. And then we'll move from that to me talking about the paper that we're going to talk about. And just for the record, let me pull this up here. The name of the paper is Risk Factors for Peri-Intubation Cardiac Arrest in a Pediatric Emergency Department. All right, so that is that's kind of an important concept. Obviously, you know, the idea of peri-intubation cardiac arrest is near and dear to my heart, but that was in an adult population. Let's see what this looks like in a pediatric population. So, Mikey, you ready to roll that beautiful bean footage?
Yep. Give me, you know, I got 3 or 4 clicks to go through. So
you bet.
I'm going to do that.
Start that click in, and I believe we are going to enjoy our Manhattan and our Manhattan old fashioned.
Yep.
And our old fashioned on the raw.
And for those of you that are watching on YouTube, which I know that there's quite a few of you, thanks for jumping over there. We'll be watching those comments, so throw them in there. All right. All right. So let me do this. Let me do this. And here we go.
Dr. Lincoln.
Hey, how's it going?
Good. How are you?
I'm good. I'm good.
First things first.
Yeah.
Let's do a quick distance assessment. I can't touch you. You
Nope.
can't touch. I think we're more than 6 feet. What do you think?
I think we are. Yeah.
I think we can
agree.
take these off.
Okay.
You know why that's important?
So we don't get dead?
No, the taking them off.
Oh, so you can hear me.
So I can hear you, and
Oh, yeah.
so we can enjoy our tasty beverage.
Absolutely.
Cheers.
Cheers. I love this glass.
Yeah. What you got there? It is the St. Arnold's, right?
In fact, St.
Yep.
Arnold's, started by some people from my alma mater in Houston.
Yeah.
Yeah.
Yeah. Rice. A
Yes.
couple of owls there.
Yeah.
I'm trying to see what this is. This is Rabbit Hole Brewing from Austin, Texas.
Okay.
And it's a little blue rabbit.
In fact.
I can't read what that says, just or something. But all right. So, Dr. Lincoln,
Yeah.
you have been on our pod before. Let's just go over it. Were you actually were a doctor already when you were on our pod before, right?
In fact, although it still doesn't feel like it, but that's
No. I have been out. I am now a PGY 15,
okay.
and it doesn't feel like it. So,
Yeah. Yeah.
That's probably a good thing.
I hope so.
So, you are a resident at the Del Seaton Medical School.
Mm-hmm.
So, let's do this. You are in the emergency department.
Okay.
And the next chart pops up, virtual chart, and it says you have an 8-month-old girl with fever and respiratory distress. That's the chief complaint on Epic or whatever electronic medical record you're forced to use.
Okay. And what time of year is it?
It is right now, as a matter of fact. So we are filming this November of 2020.
Alrighty. So certainly that raises a suspicion for some sort of respiratory virus. My first concern with any kiddos is getting in to go see them. So I'm going to walk over and kind of get my general impression of the kiddo. So what do I see, hear, and smell when I walk in the room?
You bet. So you smell coffee because the kid right next to this room apparently has had, I don't know, kids don't really have melena all that much. They can, but there was an adult in there with melena, and the nurses were trying to cover it up with coffee smell. So that's what you smell. Okay. What you see is a kid that looks sick. Your sickometer goes off. The child is on the stretcher in care of several emergency department nurses, and mom is there, and mom seems concerned. Kid looks obviously tachypnic and has some increased work of breathing. Is there anything else you would like to know when forming your general assessment, your general impression?
Yeah, I like to use the pediatric assessment triangle, and you mentioned increased work of breathing, and that's part of it. Activity, is the kid just sitting there? Are they, scared of the nurses? Are they kind of staring off?
You bet. Well, right as you walk in, so your first indication is that it's a busy ER, and there are several nurses in here, which takes quite a bit. So at least the nurses are concerned, and they're starting an IV. And you walk in right as they stick the kid, and the kid just lays there.
Oh, that's scary. That's scary. What does the skin look like?
It looks a little warm. You don't see any rashes. It looks warm. It looks a little red. That's what I was trying to say. But you don't notice any rashes. The kid is wearing a diaper, and that's about it. The nurses already have him out of the onesie.
Okay. And
Her.
Does the kiddo happen to be on the monitor so I can glance up and see pulse ox, heart rate, those sorts of things?
Yep, absolutely. And so everything is on. They've turned all the things on. You have a systolic blood pressure of 90. Your heart rate is 170. It appears regular. Respiratory rate, according to the end-tidal CO2, is 60. Okay. Your pulse ox with a good pleth is 82. The nurse is, even though it's not displayed on the monitor, nurse tells you your temperature rectally is 103 Fahrenheit. Okay. And as you look down at the super duper bed that gives you weights, it says the child weighs 10 kilograms.
Excellent. All right, so this kid is definitely sick. Like you mentioned, my sickometer is going off a lot more just hearing all of those numbers. So the first thing I want to address is that the kiddo's SATs are 82%. I'll start with, hopefully we have a device available, a non-rebreather, but would consider going to high flow nasal cannula if we need that for some respiratory support as the kiddo is breathing kind of fast. I don't have a full story yet, but I'm worried the kid's septic. Sounds like they got IV access, so I want to start with a fluid bolus, and I want to give the kiddo some Tylenol, probably some rectal Tylenol since the kiddo's breathing so fast.
All right, so let's say that you're going to use a non-rebreather mask. I do want to come back to one thing you said there.
Sure.
And fluids. Mm-hmm. Tell me how you're going to give the fluids and what fluids you're going to give.
Yeah, so I am going to give a crystalloid isotonic fluid like normal saline. I'm going to do 20 cc's per kilo as a bolus. So if we have a syringe or some kind of fancy device to give the fluids essentially all at once, the best we can.
Okay.
And then reassess and give an additional fluid bolus if needed.
You also mentioned Tylenol. Mm-hmm. You're going to give it rectally. How much are you going to give?
15 mgs per kg.
Okay.
Somewhere between 10 to 15 mgs per kg.
You bet. And then one other thing you said. So you have a child in respiratory distress who is hypoxic and tachypnic, and you're going to put a nasal cannula on? What's up with that? Is that going to work? Is that what you're saying?
Not a normal nasal cannula.
Tell me about that.
It's a high flow nasal cannula, and for kiddos we do kind of a weight-based flow, and I got to be honest, I can't remember that off the top of my head.
That's what tables are for.
Yeah. Yes. I would look up what it is, but it's a weight-based flow. And the cannula is a much higher flow rate than you'd get with a typical nasal cannula.
Okay.
It's warmed, it's humidified, so you don't end up drying out the nasal passages. And depending on who you ask, you might get a little bit of PEEP support with that as well.
Okay. Yeah, typically you do get a little. And so the key here is this is not the nasal cannula you have on your ambulance.
Right. Exactly.
The trademark one we use in our emergency department is Vapotherm, I think. Mm-hmm. But you can tell from across the room this is not a normal nasal cannula.
Right.
It looks like one of the level 1 infusers.
Yes.
So it's a big old thing. So different stuff. I think about that, and I've been using it a lot in adults during this whole COVID nonsense instead of BiPAP even. So, okay, you're going to put a non-rebreather on. You're doing 20 per kilo of fluids. You're giving some Tylenol. The nurses are getting this stuff going. What would you like to do from here?
So I've got sort of my basic resuscitation stuff started. And so while all of that's in motion, I kind of want to get a story about what's going on from the parent.
Okay. Well, this is Jessica, and I'm mom.
Okay.
And what I'm saying is Jessica looked fine. She was eating, drinking, playing, peeing, doing her normal stuff up until yesterday. And she got really fussy and started running a fever. And then, I gave her some Tylenol and it seemed to work. I don't know. What else you want to know?
You mentioned that it kind of all started yesterday. Did she have any other symptoms besides the fever and fussiness, cough?
Yeah, she had a runny nose initially, but nothing else. And then, I don't know, maybe 10 hours ago, she started with this cough. Okay. And then it just got worse and worse. And then this nasty crap started coming up. Okay.
What kind of nasty crap?
Just this phlegm.
Okay. All right. She's healthy otherwise?
She is.
Vaccinated?
Yep. Okay. She's got all the well, there's one she doesn't have just because, it's not out yet. But aside from the COVID vaccine, she's got everything else.
Okay, good. Good deal. Anybody else in the family sick?
No, nobody else, but she does go to daycare, and there have been some sick kids there.
Okay. All right. And you said she's 8 months old, is that right?
That's correct.
Okay. And normal pregnancy, no concerns for any
Correct.
problems?
Yep. Yeah, she was born on time, vaginal delivery, no complications. We both went home at the same time.
Okay, beautiful. No allergies to anything?
No,
And she's not taking any medications every day?
that is correct.
What was I just going to ask? Oh, ins and outs type questions.
You
so
bet.
Eating and drinking okay?
Not really. She was eating and drinking fine yesterday, but then today she hasn't taken anything all day,
Okay.
at least for the last 12 hours, and she's really not peeing much. Just a little bit, and what is there seems, pretty dark.
Okay, all right. No foul smelling urine?
Smells strong, but that's about it.
Okay, all right. I think that's it for my basic questions. I'm still my working diagnosis is still some sort of sepsis, dehydration, likely secondary to some sort of respiratory virus.
Okay.
So as this is all going on, I'm kind of keeping an eye on the kiddo, seeing if there's any improvement in SATs, seeing if there's any improvement in the heart rate, in the blood pressure.
Okay.
And I still need to do a physical exam. But
You
are there
bet.
any changes thus far?
She has been on the non-rebreather mask for, 5 minutes now, and her SATs are now 99%.
Okay. Improvement in her work of breathing?
Some. She's still breathing pretty hard, though,
Okay.
but some.
All right. I might still want to try the nasal cannula, the
Okay.
high flow nasal cannula on her.
Sure.
So whatever I
Absolutely.
need to do to put that in motion.
You need to type 14 things into Epic, and then basically RT has to come down from wherever upper floor they're on. So they're on their way down.
Cool. Awesome.
Now you are, you're still giving that 20 kilo bolus.
Okay. Good deal. So I'm going to take a minute to just kind of do a physical exam on my patient.
You bet.
So start kind of from the toes and work up.
Okay.
Check capillary refill. Look for any sort of rashes on the lower extremities.
So you don't see any rashes. Cap refill is, let's say when you walked in, your initial cap refill was about 4 seconds. It's probably down to about 3, and you've given maybe 5 per kilo.
Okay. And then kind of work my way up. Look at her belly. Look in the diaper.
So diaper's looking pretty clean, pretty non-urine-y.
Okay.
There's no stool there. And again, I don't know whether I answered your question about rashes, but there's no rashes.
Okay. Listen to heart, lungs. I guess I skipped the belly. So feel the belly.
Seems soft. Child didn't really seem terribly bothered by anything you're doing.
Okay, good. No palpable spleen or liver. Okay. So listen to lungs and heart.
So heart seems like a unisound.
Yeah.
Really fast. You don't hear any murmurs, rubs, gallops at 180 to the extent that you can discern those things. When you get to the chest, still some retractions, still tachypnic. Rate now is down to around 50. You don't hear any wheezing, but you do hear some rhonchi. It's louder on the right than on the left.
Got it. Okay. Just kind of look at the neck. Continue to look for retractions, that sort
You
of
bet.
thing.
You still see some, but they're not as pronounced as they were.
Good. Look in the mouth. Look in the throat. Look in the ears and the nose.
You bet. So the mouth is dry. You don't see any cracked lip. I'm sorry, you do see some cracked lips. It looks a little dry, but you don't see any desquamation. No tonsillar erythema, no swelling. What else were you looking for?
Ears.
Ears are there.
Good. Am I
they're-
able to look in them?
You can, as a matter of fact, and this is like the one child on the planet that you can actually see. The canal is clear. Eardrums are a little red, but they're not bulging at all.
Anything in the nose?
Snot.
Okay. All right. I didn't mention suctioning out the nose earlier, but if this is an RSV patient, then that's certainly going to be beneficial as well. So we can make sure and get the boogers out.
Doesn't look like that much snot.
Okay.
So classically, that much snot. RSV kids, it's like you need a surfboard.
Oh.
There's so much snot.
There's a lot.
So this is like normal sick kid snot, not RSV snot.
Got it. Okay. So the concerning thing that I think I found on exam there was the rhonchi on one side sort of louder than the other. So I'll get a chest x-ray. That makes me more concerned for a pneumonia.
Okay.
Certainly it could be viral, but with as sick as this kiddo is, I don't know that I would just want to chalk it up to a virus, until we have something that would prove otherwise. So kind of start on some empiric antibiotics.
Any labs that you would want to do? What would you like?
So a CBC, BMP or CMP, whichever is preferred. Where I work, they tend to send the BMPs and not really worry so much about the other stuff that comes with that.
And just to translate, if our listeners are from a hospital that doesn't have BMPs, that's a basic metabolic profile. It's also called a Chem 7.
Yes.
As opposed to a Chem 12 or a Chem 15, which is usually what the CMP is. All right, so CBC, BMP. What else would you like?
A blood gas.
Blood gas?
Blood gas would be potentially useful.
And you said VBG, not ABG.
Yeah.
Okay.
This poor kiddo doesn't need to be stuck. And a lactate.
Lactate. Anything else?
Blood cultures.
Blood cultures. Let's keep
Urine
the sepsis
culture,
Nazi
yeah.
off of your back. UA, urine culture.
Yep.
Okay. How about anything else you want to get? Anything else you want to get, like at the bedside?
Like at the bedside?
Yeah, for this floppy looking kid.
Oh, floppy. Probably blood sugar.
There
This
you go.
kiddo hasn't been eating. That's a good point.
Your blood glucose is 100.
Okay, well, good.
All right, and let's see. It is viral season. Anything else you want to add on?
Do I have access to some viral
Mm-hmm.
PCR testing? I would love to swab this poor kiddo for all the viruses.
Sounds good. Oh, look at that. We are starting to get some results in. So your chest x-ray pops up and you have a right middle lobe consolidation. White blood cell count is 21. Hemoglobin is 12. Crits 40. Your platelets are 350. Your CMP, sodium is, I'll run over all of them, but I'll hit the important ones. Sodium 134, chloride 100. Your bicarb is 14. BUN 40, creatinine is 1. The glucose on chemistry is 95, and I'll just do the math for you. Your anion gap is 20.
Well, thank you. I appreciate that.
You bet. Your lactate is 5.
Okay. So the bicarb's a little bit low, consistent with my elevated anion gap.
Yep. I'm sorry, you wanted a VBG also. Your pH is 7 point. I didn't write this down, so I'll make it up. Let's say 7.31. Bicarb is roughly consistent with that. We'll say, 17. And that's really about the only thing that's useful there. Obviously, your oxygen's low, but it's VBG.
Right.
By the miracle of podcasting, your viral panel comes back. COVID is negative. Influenza A and B are negative. RSV is negative. All the things are negative. All right, so I'll tell you what. Why don't we... I should have asked you this before we got the results, but what was your differential diagnosis when you walked out of the room for the first time?
When I walked out of the room?
Out of the room. So you didn't have, all you had was your assessment, your history, and the vital signs.
Yeah, so definitely worried about pneumonia, just
Okay.
based on my physical exam findings, the respiratory issues that the patient's having. It could be sepsis for another reason, like a urinary tract infection. But with a bronchi, that seems probably less likely.
And then we mentioned the hypoglycemia.
Yeah. Yep.
Always important to check. So you have given a 20 ml bolus.
Mm-hmm.
Cap refill is still 3.
Yes.
Work of breathing is still, it's better. Your SATs look great. What would you like to do at that point?
Yeah, another 20 per kilo bolus.
Perfect. So I trained at Scott and White in Temple. One of our pediatric intensivists was Dr. Hardy. And he had this little phrase, bolus better, bolus better, bolus better. So give a bolus, reassess. If they're not better, give another bolus. Yep, on your second bolus, cap refill is under 2. Kid is now appropriately pissed off, but easily comforted by mom. She is looking around, making good eye contact, and her work of breathing is way down.
Awesome.
So what is, as an ER doc, you have one last thing you need to do. You got to dispo this kid. What you going to do?
So I do think this kiddo needs to be admitted. Even though she's looking better, the fact that she tanked so quickly after a day is worrisome. I think it'd be nice to get her some IV antibiotics and just make sure that she does okay.
Absolutely. I think that looks great.
Yeah.
Awesome. So I think we hit on the key things here. Dr. Lincoln, thank you so much. I appreciate it.
Absolutely. Thanks for having me.
You bet. Howdy, y'all. This is Dr. Jeff Jarvis. Y'all probably already know that I have a passion for airway management. In particular, doing intubation correctly. Now, this means avoiding the complications of intubation that are clearly known. In the adult world, there is extensive literature that tells us the following. First pass success is important. Failure to successfully intubate on the first pass is associated with over 652% higher odds of increased adverse events compared to those intubated on the first attempt, and the most common of these events is hypoxia. The more attempts, the more adverse events. Hypoxia prior to the intubation attempt leads to more profound hypoxia during the attempt. Peri-intubation hypoxia is important because it can lead to cardiac arrest. In adult patients, whether in the OR, the ED, or in the field, approximately 2 to 4% of all RSIs result in cardiac arrest, and hypoxia is the most common cause. Elevated shock index, and as a reminder, shock index is heart rate divided by systolic blood pressure, using succinylcholine, hypotension, and hypoxia were all predictors of peri-intubation cardiac arrest. So there really is substantial evidence in adults for peri-intubation cardiac arrest. But what about in children? Now, there is evidence for this in the non-emergency department setting, including the OR and ICU, where hypoxia, hypotension, and multiple intubation attempts have been associated with peri-intubation cardiac arrest. But what about in the emergency department? What are the risk factors for peri-intubation cardiac arrest in the pediatric emergency department? And from that, we can extrapolate to the field. What are they? Well, I'm glad you asked, because that is exactly the question that this episode's paper is all about. In fact, it's also the title. This paper by Dr. Pokrajak and colleagues was published recently in Pediatric Emergency Care. Now, I thought it was a good paper to remind us of the characteristics, some of them modifiable, that might help us make intubation in the pediatric population safer. And if I'm being completely honest here, and I'm an Aggie, I like to be honest, I'm also doing it because it gives me an opportunity to again beat my favorite drum. Peri-intubation hypoxia is common, it's harmful, and it's avoidable, whether in adults or pediatric patients. All right. Now that that drum is well and truly beat, let's get back to this paper. This was a single center case control study from a large pediatric emergency department in San Diego. It is an impressively large and busy center. They report having 60 rooms and seeing over 100,000 pediatric patients a year. That is really big, and it is really busy. So they did a retrospective chart review of cases from between January of 2009 and August of 2017, where a child under the age of 18 underwent emergent intubation. They excluded any patient with intubation done outside the ED, like say in the field prior to arrival, as well as any intubation done for a patient already in cardiac arrest. They then broke this larger population into two subgroups. Those who had a peri-intubation cardiac arrest, and they defined peri-intubation as within 20 minutes following intubation, and those who did not. Now, obviously, the non-arrest group is going to be larger than the arrest group, thankfully. Most patients who are intubated don't go into cardiac arrest. Now, to create a better comparison group, they randomly picked 4 controls for each case. Now, the cases were those who had a peri-intubation arrest and the controls were those who didn't. So for each case, they picked 4 controls. They then compared the characteristics of each group to identify risks associated with arrest. And finally, they tested several models for prediction of peri-intubation arrest based on their results. And the idea behind this model is if we have a rule, we might be able to say, hey, if patients have these things, they are at higher risk for arrest. See what you can do about those. All right, so let's dig into these methods just a bit. They had a really interesting approach to identifying intubations. So they did a free text search in their EMR, electronic medical record, for a bunch of different ways of saying intubation. Separately, they searched all records for respiratory therapy notes about endotracheal tube depth of insertion. It's not likely RT would be talking about ET depth of insertion if there was no ET to be inserted at any depth. Pretty good way to find these. Now, after combining these searches, they did a manual abstraction, meaning they went in and pulled information out of those charts based on definitions that they came up with and using an abstraction form that they developed a priori, meaning before they started pulling the data. And that's just the right thing to do. Now, there were 2 abstractors who looked at all charts, and there was good inter-rater reliability between the 2. Now, they also had a 3rd tiebreaker who reviewed any discrepancies that the 2 had. Much of their data on timing and drugs comes from real-time data collection forms completed by nurses at the bedside during the intubation attempt. This form collects things like the number of intubation attempts, times of attempts, drugs, doses, and times of administration, as well as the name and academic level and specialty of the intubating physician. Now, that's not a guarantee, but this methodology really goes a long way to improving my faith in the accuracy of the data. One specific thing here is that it was not the provider reporting whether they succeeded or how many attempts they took. It was an independent observer. The nurse at the bedside is the one who filled in those forms. Now, it does not appear that they did any type of matching of controls to cases, and they certainly didn't do any propensity matching. One of their stated reasons for not doing so is that they were trying to identify potential risk factors, and many of the criteria that they would typically match on, like age and gender, are potential risk factors. And therefore, if they did propensity matching, it would decrease their ability to identify what those risk factors were. Now, finally, they were pretty clear this was a preliminary exploration and derivation study that would need separate validation. So basically, when you're trying to identify risk factors or come up with a prediction rule, you go through an exploration phase and then a derivation phase. And then once you've derived a rule, you need to go through and validate that rule using a separate data set. And that is what they have not done yet. All right, so they ultimately identified 543 patients with an emergency department intubation, of which 21 had a peri-intubation arrest. So 21 had a peri-intubation arrest, 524 did not. They randomly selected 84 control patients from the larger group, i.e. the ones who didn't have an arrest, and those were their comparator groups. The groups who did, or the patients who did have an arrest, and then those 84 that did not. And again, that's a 4-to-1 match. Now, using these 2 groups, they looked for differences between them on multiple factors. Now, they chose these factors based on expert opinion, on pre-existing literature, and on physiologic plausibility. They investigated the following factors for differences to gauge their usefulness as potential predictors. All right, here's the list. Hypotension, abnormal heart rate, shock index, delayed capillary refill, hypoxia, which they define as anything less than 92, age, sex, any comorbidities, Nighttime intubation. Now that one is interesting. Does getting intubated at night as opposed to during the day increase your odds of peri-intubation arrest? Good question. How about the number of attempts, the indication for intubation, what the intubating physician's specialty and years of training were, and any interventions performed prior to intubation? For abnormal vital signs, they used PALS age-adjusted cutoffs. So that's how they defined what was abnormal. All right, so what did they find? Patients in the arrest group were younger, and that was basically 1.5 years versus 3 years, median age between the two groups. So 1.5 years in the arrest group, 3 years in the non-arrest group. There was a larger proportion of patients in the arrest group that were younger than 1 year old, and that was 43 in the arrest group versus 16 in the non-arrest group. Children in the arrest group were also more likely to have comorbid pulmonary disease. So the following characteristics were associated with peri-intubation cardiac arrest. And so here are these factors with their odds ratio. And remember, an odds ratio of 1 is no difference. The higher the odds are, the higher the odds ratio is, the higher the odds are. So the first one is hypotension, and it has an odds ratio of 17.3. That's pretty big. So odds ratio of 17.3 for hypotension. Hypoxia or an unobtainable SpO2, meaning they just couldn't measure it, 66 odds ratio. No paralytic used had an odds ratio of 12.8. No sedative used, an odds ratio of 24.5. And more than one endotracheal intubation attempt had an odds ratio of 5.3. There were no significant differences in heart rate, shock index, receiving a fluid bolus prior to intubation, the indication for intubation, intubator's specialty or level of training, and whether the intubation was done on a night shift or a day shift. Now, the authors developed several prediction rules based on these findings. They basically were age less than 1 year plus the presence of hypoxia or not, and those were given the strengths of those two associations. Now, they looked at the group of patients who were under 1 year of age and had hypoxia. 100% of those went into cardiac arrest versus 29% over 1 year with hypoxia. The probability of arrest without hypoxia was 6% if they were under 1 year old and 1% if they were over 1 year old. Again, statistically significant. Now let's talk limitations. The primary limitation of this paper is that it is a retrospective chart review. As such, it can only determine association and not causation. The finding that lack of a sedative or a paralytic is associated with more arrest, that is likely an indication bias. In other words, there was probably a reason that the physicians chose not to give a sedative or a paralytic. Maybe they were already peri-arrest when they were intubated. Finally, the risk model they developed, and that is hypoxic and less than 1 year old, needs to be externally validated with a different data set. So what was their conclusion? Hypoxia, age younger than 1, multiple intubation attempts, and hypotension or delayed cap refill as a surrogate for hypotension were all associated independently with higher odds of peri-intubation cardiac arrest. Now, I think they did a nice job demonstrating these associations. And while it is not evidence of causation, I think these findings are likely real. They're consistent with prior studies of pediatric patients in other hospital settings, and they're consistent with an abundance of evidence in multiple settings in adult populations. It is not a wise plan to proceed with intubation in profoundly sick kids, particularly young kids. These patients should be adequately resuscitated before they're intubated. Now, if this isn't possible, rapidly place a supraglottic airway to aid in that resuscitation, and then once they're adequately pre-oxygenated and no longer hypotensive or hypoxic, then go ahead and swap out the supraglottic with an endotracheal tube if you absolutely must. So that's my bottom line. I think that this is not definitive, but it is a great reminder of the things to watch for. We already know hypotension and hypoxia are bad. We need to fix those things before we intubate. What this paper really adds is that so is age under 1 year old. So we can't really make them over 1 year old. That would be a delay in intubation that's probably a bit excessive. But we can be aware of it and be maximally prepared. All right, guys, I hope that you got something out of this paper. Thanks again. Thanks for what you do. Take care, y'all.
All right. Well, great paper. Great review. Good case. Like, it was all good.
I like it. I like it.
Great job, Jeff. That was awesome, man.
Well, thank you. Thank you. So the nice thing about this is that while this is the whole reason that I pre-record these. So we're playing them, and me and Mike and Peter get up, go to the bathroom, and get a refill. That's the real reason.
If you could have only seen our three-way chat going, it was phenomenal.
It was lots of fun.
It was
so
good.
I will say a couple of things. One, for my buddy Jay-Z, I humbly apologize. Please forgive me, my friend. I did not find a way to get a waterfall plot worked in here, but Texas is a delegated practice state. So
it's a matter of time.
Hey, Jeff, slide to the right so people could see your full, beautiful face in the middle of the screen. No, other way. Yeah,
well, I don't want to be blocking my friends back here. I put them up just for Ratu.
And in the view that we're using on Social Live, though, you can't see that.
Yeah, you can.
Oh, that's
they're commenting on that.
What are you seeing on Social Live, perhaps I should ask?
Just that half your face is out of the frame.
Am I back?
Other way.
Oh, it's delayed. That's the reason.
Yes.
That's not the reason.
All right, let's see. Where do you need me?
No.
There?
No, go the other way, bro.
Other way.
Right there you go. Right
there you go.
Oh, I spend so much time setting this perfect view up to get my Christmas stuffed animals in the set, and then it just gets messed up. That is so sad. Peter, so let's talk about this paper real quickly. Sort of some takeaways. What were you thinking? Your takeaways on things to watch for as predictors of peri-intubation cardiac arrest and things that you can modify. Notice how I threw you under the bus there?
Well, you guys all know that I'm a big believer in that we should treat kids the same as we do adults. And, you know, it oftentimes pains me to see, and again, I was guilty of this and I've kind of lived through this for a long time, is that they throw you a kid in the ED who's not doing well. And the first thing you want to do is just pick up the blade and pick up your tube and go to work.
Yeah.
And I've seen it too many times. That's number one. The second thing I see oftentimes, especially when the ICU doc comes down or somebody else who comes down to take over the code in the emergency department, is that they're looking and you hear the monitor go boop, 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 and people are saying, SATs 85, okay, 80. 75.
I've almost got it. I'm almost
there. And they just keep on because they're going to get it, right? And so, you know, I've made the mistake, Jeff and Mike, I could tell you early on in my career where I would say, oh, that's the ICU doctor. And I kid you not, we had a patient who went, I'm laughing because the kid lived. Thank God or else I would be telling the story probably, but the SATs went down to 0. Okay, so we saw the thing go down to 0.
So what you're saying, just as a reminder, room air is 21%. You were, instead of oxygenating, you were actively deoxygenating.
Correct. And even better is that, you know, even with all the airway maneuvers we can get, we knew this kid's airway was like the size of a toothpick. Yeah. And this guy was, you know, he was just adamant about getting in. So he finally gets it in. and he has to corkscrew the tube into the airway. That's how tight this kid's airway was. And so I'm breathing a sigh of relief. The kid didn't die in my emergency department. Anesthesia comes in and says, wait a minute, we got to change out this tube. I'm like, it gets really stupid really fast. Even in a hospital, we see 80,000 kids a year. We're at level 1 trauma center, we see it all. And it just gets really dumb really fast in an emergency department. And so if it was me in the field, it would have been an eye gel or an LMA or something like that. Obviously, we use the eye gel. And people do stupid things. So at the end of the day, we see why it happens that children go hypoxic. We see why people don't tend to the blood pressure. If you read this paper, it talks all about the fact that most of the time the blood pressure was never ascertained, right? And so what does that say? That the kid probably didn't have a good blood pressure. They couldn't get a good pleth wave on the O2 sat. And what are they doing? They're rushing to intubate, right? What we've learned from you, and completely changed the culture in Coral Springs, and now we're doing it in Palm Beach County Fire, is
all
that
the way to Oregon.
All the way to Oregon is we said, damn it, slow down, take your time, maximize. So we do fluids, we do push pressure epi, we maximize the oxygenation, we have the checklist, we have our little timer, and at the end of the day, we have much better outcomes. Similar to what you showed, I think your paper was like 44% versus 3%. I forget the numbers exactly.
No, I think you remember them. You nailed it, Peter.
There you go. So, that's the kind of data we're seeing. Our first pass success has improved significantly. We use video. But I can tell you that if you walk into any pediatric emergency department today, you will see a lot of this shenanigans. And I hate to say it, it's 2020. Maybe in 2025, they'll be doing DSI instead of RSI. So, I unfortunately read this paper and see what's in it. But and it's exactly what you showed in kind of a different way. Right?
I think you're right. So I'll tell you I'll summarize my take home, which I think is very similar to yours to your primary point. But as a primarily adult emergency physician, I can't pass the opportunity to say this. My takeaway is when it comes to risk factors for peri-intubation, hypoxia, and cardiac arrest, kids really are just little adults. It's the same damn thing. So the one addition, so hypoxia, hypotension, fix them first, then proceed with intubation. Slow the hell down. For me, that's honestly the reason I picked this paper, is because it would give me an opportunity to say there's nothing different about kids. Treat them the same on this. Now, one thing that is a little bit different, and I'm going to use this as a segue to answer some of Dane and Sam's questions from YouTube, is that in the paper, age was a predictor. Now, I guess you technically speaking can improve the age before you intubate, but I'm thinking that might take a little too long. So now, based on the length of stay in my ED today, we might get there, but I don't think we want to let them age out of this problem. But Sam was asking, it was either Sam or Dane, was asking a problem about, or a question about the influence of age on success rates and iGel versus endotracheal intubation. So as I mentioned, I think I've said this several times, and I mentioned in the show notes or the chat here, my systems don't intubate kids. Now, the reason we don't intubate kids is not because I don't think they can do it. I have a great deal of faith in the paramedics that I'm privileged to work with. I think they're very skilled, but we average number, recognizing what Rimley would say about averages. On the average room, every person has one testicle and one ovary. So there's a limited value to that. But on average, we would do 1.5 intubations every 2.5 careers. So every 40 years, we would do 1.5 intubations of a child. The numbers just are not there to justify the investment it would take when we have a device like an iGel that works just as well. Now, I took a look at using the ESO data set, research data set. I did a paper that looked at age and intubation success rate and supraglottic success rate as a function of age. And what I saw was this huge increase in first pass success rate with intubation. So the older you got, the higher your first pass success rate was. When you were younger, it sucked. So this is another way of saying the younger you got, the worse your first pass success rate was with intubation. But the line with supraglottics was flat. So there was no association with age. So we are much more successful with supraglottics than we are with intubation in kids. Now, another question I saw was, it was a great question, and unfortunately, I can't read my own damn handwriting.
Go ahead.
Yeah, go ahead.
I was just going to say, did you previously have it okay to intubate kids and then decided to not do that based on your information?
Yep. Yeah, it turns out we sucked at it.
That's a pretty bold step, because I mean, if you think of, all the research out of San Diego, right? The paper, right, out of San Diego in kids.
Don't get me started on that.
I'm not going to get you started. I'm just saying that's what people use, right? But
so are you talking about BVM versus
the
Marianne?
That's what he's talking about.
Yeah. Okay.
But that's a pretty. When did you take away? This makes it sound terrible, but when did you stop doing intubation on kids? Like what year ish?
13, 14. So Marianne's paper was, and it was actually LA County. They did a randomized control trial of BVM compared to intubation in a system that had not done pediatric intubation to begin with. So the intubation was the new thing. And they did a lot of additional training in BVM, which I would argue is not there. And I think we really do a poor job of it because we do a poor job training. So I think it's our fault as medical directors and educators. And they compared it to intubation and showed that there was no difference in survival. Definitely some challenges, and that is an old paper now.
Yeah, of course.
Yep. But no, we did it based on two functions. We saw that our overall first pass success rate was around 46, 47%. We're using DL. We're intubating kids and adults. And I looked at our data. I looked at how often we are intubating kids. Again, 1.5 every 2.5 careers, and said, that's not where I want to put my improvement efforts. We have an iGel. It works well. We're going to do the iGel, and then we're going to put our improvement efforts into adopting video laryngoscopy and the training needed for adult intubation. And our adult intubation success rates are much higher now. So
was there uproar? Was there torches and pitchforks? Like, God damn, away their intubation.
Hold on. Right. Guys, hold on, because I have to comment on the February 2000 JAMA article from Marianne Verkest. It was a 3-year study, 830.
Hey, I'm going to go ahead and pull your string and let you go. So buddy. What you got?
Yeah. Okay. So remember, this was done before. It was from 1994 until 1997. Some people watching this weren't even born yet. Okay, that's number one.
That was an unnecessary comment.
The paramedics received 2 3-hour training sessions on how to intubate when they had never intubated before. Wow. Their marker of a successful intubation was good chest rise. And basically 30 patients had an esophageal intubation. However, the thing that, that people forget, we didn't have a quantitative end-tidal CO2. We didn't have waveform capnography. We didn't have supraglottics. We didn't have VL. We didn't have ketamine. And you could have gotten trained. Remember, it's a 3-year study. You could have gotten trained in March of 1994, and you could have intubated for the first time, like you had mentioned earlier, in January of 1997. And so we should not, it's like, Jeff, you were mentioning on the chat, on a private chat, that you just got the iPhone 12.
Pro.
This is, okay, Pro Max, right?
I got the Pro.
The big man was the Pro Max. I'm a little guy.
Oh, okay, right. Mike's got the big bucks with the Pro Max. So imagine, Mike, you're talking about the brick phone, the Motorola. You guys remember that one? I'm sure Joseph Zalkin and I remember that quite well.
Yeah, Jay-Z's got one still. I'm sure.
Right. So we should not be using that study, right, to compare what is done in the field. But I will say, Jeff, I do agree that we now use iGel primarily for cardiac arrest. However, if you're in a tiered system, if you have a small cadre of paramedics that you can train and do the right training, for example, Palm Beach County Fire, we had 2 children, an 8 and a 10-year-old, in a fire, a house fire. You know, they had the soot, they were hypoxic, they were in trouble, they were circling the drain. We DSI'd those patients, those kids, and they did very well. And so, I don't want to throw the baby out with the bathwater, number one. Secondly, there's a medical director in my county, and I just put him on our webinar. We do a weekly webinar. He has now removed endotracheal intubation completely because every year they were getting esophageal intubation. So that's not a system that should intubate. So whoever's watching today, I do agree that intubation has taken a back seat, but I don't think it's completely gone forever. And you will need a patient, you will need to intubate patients with an ET tube who need higher pressures, use a cuff tube, don't have to inflate it if you don't need to. But if then again, you're 5 minutes away from the hospital, the iGel will probably work just fine if you're someone who can take an iGel without gagging. So there's that fine line of an iGel will work. Jeff, you may want to comment. Do you allow ketamine only with iGel following? Because I agree with that too. We allow that. So it's not just a black and white issue with cardiac arrest gets iGel. That's an easy one. That's a yes, 100%. It's the other patient population that, and if you're 30, 40, 50 minutes away from an emergency department, that the iGel may be good enough, yes, but you may need medications affiliated with that iGel rather than just shoving it in. And I'll stop there.
Absolutely. So, and that is a great segue to answer one of Dane's questions. Dane was just full of great questions. I love it. So one of the things that he asked was, do you need sedation and paralytics for iGels? And by the way, when we say iGel, you can substitute LMA or AirQ. It's any of the supraglottic devices. And honestly, if you want to dump in some extraglottic devices, meaning the King LT, knock yourself out. It applies to all of these. So the question is, do you need to use sedation and paralytics with them? And I think it depends. Just like you don't need to use intubation and paralytics to intubate. So if you have someone who is completely unconscious, has no gag reflex, that goes along nicely with their lack of a pulse in cardiac arrest, and you can go ahead and intubate without using sedation or neuromuscular blocker, yes, absolutely.
That's a different story, right?
But I absolutely believe if you were doing this outside of cardiac arrest, I think we have to assume the patient is aware, has sensation, can feel this, and yes, I think you should use sedation. The question about whether you need paralytics or not, I think is a little bit different. So we do not, Peter, use ketamine only. And I know Mark Peel just loves to argue with me about this. Yes. We don't do ketamine only intubation or supraglottics. We will use, and Darren Brody coined the term RSA, rapid sequence airway. And basically what he's talking about there is something we adopted, and that's using a sedative, a paralytic to place a supraglottic. And we do, and we'll actually, that's our primary approach if we are going down a DSI pathway for adults and we can't meet our metrics for intubating, mean we can't get the SATs up, we can't get the pressure up, we need to control their airway, absolutely drop an iGel. And if you feel like you need to use a paralytic, knock yourself out. Do it with a sedative. Yeah.
Right. So what I would say, let's take the severe asthmatic, right? It's a patient whose their preload is down. They're relying on that negative pressure that negative pressure breath to fill up that RV so that they can actually get some, pressure to their brain. Okay. And then now they're air stacking. Their lungs are so full of air that they're basically squeezing down the heart. And then here you come and you say, oh my gosh, this person is, tachypnic and their end-tidal capnography is way off and so forth. Let me paralyze them to intubate them, and then they die, right? So that patient, in my protocol, it's ketamine, and maybe the ketamine alone will do the trick. But if you paralyze that patient and take away their negative pressure from them, you kill them on the spot, right? So I'm in the Mark Peel camp for some patients that you can give someone enough ketamine, up to 4 per kilo of ketamine, knock them the hell out, right? And then you can do anything. And we've been very successful. So I give my medics the ability to say, we're starting through the Jeff Jarvis DSI protocol, ketamine, boom. They get better, we're done, okay? Maybe we don't want to intubate them, the severe asthmatic, throw it, don't paralyze them until after you intubate them. So I allow them to look. If there's no gag and they have no problem getting the airway, we get the airway and then we paralyze. And so I think there's a lot of different ways to skin the cat here, but I am a big believer that, listen, Mark Peel is a smart guy, right? And
wicked smart.
Right, wicked smart. And I can give anyone here enough ketamine to knock you out, and then I can just go right into your airway and I can intubate you, not a problem. So he does have a very good point, but I think it has to be VL. You can't be going and manipulating someone's airway with DL. I think if you're going to use a ketamine only approach, you either have to have a supraglottic or you have to have VL and nicely slide that airway right in through the vocal cord. So it's nuanced, obviously, but I think that you have to work in a system that has a smaller cadre of individuals that are trained up, rather than trying to train up. Like, I can't train up 1,500 medics at Palm Beach County Fire Rescue, but I can take my 60 EMS captains, and we've given them ultrasound. We do finger thoracostomy. We rely on them to do that, the really high end stuff. So that's the kind of system that I work in, which is maybe different than what the people are listening.
So, with the caveat that Peter Antevy and Mark Peel are both brilliant clinicians whose opinion I absolutely recognize and value. Peter, you ignorant slut. Now, I don't necessarily disagree with you. I just had to find a way to use that line. So here is my argument for and this, we're probably a little off the topic, and the truth is that there's not really a right answer to this. How's that low and slow out the nose, Peter? So my answer on this is yes, you should be able to theoretically have equal success rates, first pass success rates with ketamine only that you do with ketamine and paralytics. You should. But butterflies and bumblebees also should not be able to fly, yet they do. And when you look at the literature, it says first pass success rates are consistently and reproducibly higher with a paralytic. And that's what I am aiming at. Are there isolated cases where a ketamine only intubation, an awake intubation, if you will, are appropriate? Yeah. Absolutely.
Absolutely.
But I believe that, and there are cases like that where I would do this in the emergency department. But when you're writing protocols, you can't write protocols for the individual patient. You do it for a larger cadre of patients, and that's the reason I'm doing it. So that's my exaggerated opinion to prove a point, to debate the point. The bottom line is I think both of them are very reasonable approaches. But I couldn't say, Peter, you ignorant slut, if I said that you had a reasonable point.
Well, let me tell you what, I'm going to argue against myself and with you. Because
hop on board. The water's great over here.
Let me tell you what, I'm going to brag on my fire chief a little bit and my EMS chief. So one of my agencies is a small little department. We see about 14,000 runs a year. Population, it's the city I live in, actually, Davie, Florida. And since April 2017, we have 23 CPC 1 or 2 survivors. We do not have any paralytics. We don't have any, we have Versed, but we don't use it basically. It's an agency where we use iGel and we allow them to intubate if they want to, but it's without medication assistance. And so we're 5 to 10 minutes away from the hospital. And so we won the International Association of Fire Chiefs Heart Safe Award unanimously at a little city. Why? It's not because of it's probably a little bit because of the airway stuff, but it's more because of the fact that we practice good quality BLS, high performance CPR, and we can attend to the airway enough rather than we focus on the airway and lose track of the things that count. So if you came to my emergency department, I hate to say it, and Helen is an amazing nurse, and hope she's not watching the podcast, Mike. Right. She's 4 feet tall. Okay. She's 4 foot tall. And anytime there's a code, Helen is there with 2 stools doing CPR like this on a child, right?
Oh, that kind of stool.
Yeah. So BLS inside of a hospital, and I know I see Brandon's on the call and a lot of hospital people here, but like it's done really, really poorly.
Yeah. And
so when I read papers like this, Jeff, I could tell you that there's no doubt in my mind that there's peri-intubation arrest, not only because of the hypoxia and the mismanagement of the blood pressure beforehand, but because of the fact that the basic BLS structure and the high performance CPR does not exist inside of a hospital system.
No doubt.
Period.
And the monitoring. I will tell you, I was working with one of my partners, Dr. Peter Richardson today, and we had a gentleman that we needed to do a procedure on. Okay. So I needed a deep sedation. So I'm going to do the thing to him, which is not going to be pleasant. And he doesn't really need to be present for us doing this. So I waited until Pete came in, and he did an outstanding job doing the sedation. He used propofol, put the guy down deep so I could do the thing. Yeah. And in this case, the resident did the thing. But when I walk in the room, it made me so happy. I walk in, the guy is on oxygen, on capnography. He's got all the monitors on. And Pete is talking to the resident about why we're using capnography as a precursor to or as a way to identify respiratory depression before they become hypoxic, in the context of someone we are hyperoxygenating and denitrogenating to buy us time if and when he does have apnea, because we pop him with get him a little too deep, or more than likely we get him deep enough for me to do the thing to him, and then I'm done with whatever painful thing it is. The stimulation goes away, and now he goes deep. Yeah. So I just, as a shout out to my partner, Pete did a great job on that. I think, unfortunately, outside of procedural sedation, when it comes to intubation, now Pete is great with that also, but I think too many of our colleagues think you just got to get the tube in, the exact mindset that our too many paramedic colleagues have. Absolutely. So I'll tell you what, we're getting some great comments in here. One was from Sam, who I didn't know this, but was a dental assistant in her background. Awesome.
That's awesome. Wow.
And she was talking about dental procedures that push the tongue down and make the patient uncomfortable. And I think where she's getting that is not necessarily back, but like down, not to occlude the airway. And that's uncomfortable. And she says, well, what about a little ketamine? So the catch with ketamine is that it is very dose dependent. If you have dissociative doses, typically under 0.3 per kilo, you will remain conscious and get a little bit of analgesia. It's not the world's best chill you out medicine. Benzos are great for just taking the edge off. Yeah. But ketamine really is a good drug for dental procedures to just take them out altogether, because in the vast majority of patients, you maintain airway reflexes. Yeah. I would recommend, and y'all have those little thingies that work great for suction, because ketamine can increase sedation. Yeah, but the little hangy downy thing that.
Oh yeah, I need that suction.
great big decanto, you know,
Yeah.
tool of war that we use when intubating.
Yeah, it's no decanto, but it's not bad.
So there was another question that, and I'm sorry, I was trying to pay attention to Peter and look at the question, but it looked as though it was asking about sympatholysis during intubation and then also about vagal stimulation. So one thing that I've noticed, and this is not specific to kids, but I've noticed that people will frequently add in atropine to their RSI because what they're doing is what they think they're doing is trying to prevent bradycardia. That's not the reason we give atropine. We give atropine because it decreases secretions from some of the other medications we do and makes it a prettier airway. If you want to prevent bradycardia during an intubation, don't let them get hypoxic. It's the hypoxia. And if we go back and we take out our physiology, go get Guyton and look at Guyton. By the way, that's my recommendation. If you want a textbook, read Guyton's Physiology, the single best textbook I ever had in medical school. What he will tell you is atropine doesn't do shit for hypoxia.
That's the medical term. I mean,
correct.
Okay. So I completely agree with you that you give. So here you are in the ED or anywhere, and you have a little infant that you're about to intubate, and you give the atropine to. If you hadn't given them the atropine, because we all know that the O2 sat lags behind reality, right?
Sure does.
Right. And so here you are in there, but the heart rate is a pretty good indicator. So you have the O2 sat looking pretty good, but the kid's heart rate is now going from 130 to 110 to 90 to 80. And someone's saying, oh, those sats look pretty good. But at the end of the day, if you do not give atropine, you can use the heart rate to know when you're about to go to hell, okay? You give atropine, you now lose that ability to do that. But let's just take a review of the data here. This is in 2015, the guidelines came and said atropine for pre-intubation, it's not supported. Routine use is not supported. It is reasonable if succinylcholine is used. But if you look at the data that they pulled upon from that study, from those studies, in children in children who are in infancy, the children about over 28 days of life, there's about 264 kids in that study. It supported the use. In the other two studies, it reduced the incidence of arrhythmia. There was no harm. There's no harm in giving atropine, but it's probably not necessary. And like you said, Jeff, it doesn't fix anything. Yeah. And in reality, it may trick you into thinking that everything is okay. But if your O2 sat is now coming down to like 70, you know that was probably happening like a minute ago. So absolutely. You're actually taking away the heart rate as a marker for you should probably stop and bag this kid back to life. So that's it.
So I really like that point, and that's not one that I'd really considered before. The one thing I don't want to leave people with the impression of is that laryngoscopy, yes, mucking around in the back of an airway. I don't want to leave the impression that is not a vagal stimulus. So it absolutely is.
It absolutely is.
So I don't want to leave that impression. The catch, and I'll get Peter's impression on this in pediatrics, but I'll tell you in adults, the way to decrease that stimulation is not atropine. It is, number one, don't muck around in the airway, know what you're doing and being better at it. But number two, if you want to decrease the stimulation, use fentanyl. So that is, I think, a better way of decreasing the stimulation than giving atropine. The one thing I will say here about, and I know this isn't what Peter was thinking about the no harm in atropine. I think there is harm, not necessarily from the drug itself, but from the added complexity of the procedure. And when you're doing a procedure where you have to give atropine and lidocaine and fentanyl and Iovnut and tofrog and boil it all up, it just gets so damn complicated that you miss what's important. So I agree. There's no danger in the atropine itself. I just worry about the complexity.
I 100% agree with you. And what I would say to the first statement you made is, and again, this is like a Mark Peel thing, and he has videos on this, is that when you're doing DL and you're taking that blade and you're pulling up on everything, that's a whole different ball game than when you're using VL. You're going in, it goes along to the anatomy, and you can just slide that tube right over that stylet beautifully right in, and nothing has moved, right? So I think that using VL, knowing how to do it. So when Mark talks about the ketamine only intubation, you have to have a technique and be good enough to be able to not move anything and just go in almost like you're in the dark at night and just doing it. So I think that has changed the game for us. And I think that people who are really good at VL and understand that know that vagal response is a lot less when you're not doing that. You know what I'm saying?
Absolutely. And so I'm a huge, I don't think this is going to come as a shock to anybody. As a matter of fact, Jay-Z may have to take another drink when I say this, but I'm a huge VL fan, particularly not. So someone asked about our favorite VL devices. The one thing I want to take, the point I want to make here is that when you're looking at video laryngoscopy, and we are so far off the topic here, but what the hell, I'm enjoying this. You have to think about blade geometry. There is what is essentially a standard Mac geometry. And for the most part, that is a Macintosh blade with a camera and a light attached to it so that you can see. The technique is more or less the same. Couple of tweaks, but the technique is more or less the same. And then you have a hyperacute angled blade. Technique is completely different. And in adults, I am all about that hyperacute angle blade. And I think you can get instead of having to lift tissues up and out of the way, you can just go right around the corner, much less manipulation, much less vagal stimulation. And I think you get a better view. And if you know what you're doing, tube delivery isn't really that different. But that's very much a personal preference thing. Peter, what do you think?
I completely agree with you. I think that, you'll see a lot of different flavors of people. Like, for example, we use, and again, we're moving away from the King Vision now in my EMS system because of the fact that it doesn't record.
Yeah.
But
a pox on your house. I'm looking at you, Ambu. A pox on your house. Shame on you.
That's right. Shame on you. But and in my emergency department, people are asking what do you like the best? I mean, we use GlideScope. I'm not a big fan because you got the screen over here and the patient's over here, and you're kind of doing one of those things. It doesn't really add up. I mean, I think the CMAX is a beautiful thing, but again, oftentimes when you're at a hospital system and they pour a lot of money into a product, and again, my hospital fits into this category. They end up sticking with the product, even though there are other products that are out there that are better. So.
Yeah.
The really cool thing, my hospital poured a lot of money into GlideScope. And I went into, I was up in an ICU intubating a patient, and I said, look, I bring my King Vision in because I really like it, despite the fact that Ambu's letting me down here and not recording. I have given them like 5 years of fair warning. I think I can call them out on this. I love the King Vision minus the recording part. So I let a resident use the King Vision on the first intubation. It was a COVID patient, and they didn't have a whole lot of physiologic reserve. So they went in and got ahead of the suction calf, spooged the camera, and came out. I'm like, well, I brought one blade. So now when I come in, we're going to back out. We're going to ventilate the patient up again, got him good and saturated. And I said, well, go ahead and give me the GlideScope. And they handed me this thing. And I'm like, this is not a GlideScope. Yeah, it is. It's a GlideScope. Dude, this is heavy metal. I can take you out if I hit you with this. This is screaming German engineering. This is the CMAC. And the hospital had just changed everything over to CMAC.
Really?
Yeah. Now they have a D blade, so they have a hyperacute angle blade. I think it's great. I agree with you.
It's expensive though. That's the problem.
Yep.
Very expensive.
Well, Mikey, one thing I wanted to do, I think we probably ought to
we're at
it out
here.
I really wanted to talk about two things. Just a question. Nick, early on in the questions, ask about vaccinations.
Yeah.
Y'all going to get vaccinated? And we're obviously talking about COVID here.
Of course. So you're asking if I'm going to get vaccinated?
Yeah, Mike. What do you think?
I don't know, man. I don't know if I'm ready for the 5G in my bloodstream, bro.
Dude, I just paid.
Of course I'm going to get it.
$1,000 freaking dollars for 5G on this, and you're going to give it to me for free? Hell yeah, sign me up.
Of course I'm going to get it. Thankfully, in Oregon, EMS providers, firefighters, frontline healthcare workers, all that, we're in Group 1A. And I just attended a meeting earlier today, 3:00 Pacific time, actually. And if I just go back here, we are expecting our first doses to be here, 35,100 of the Pfizer on December 15th, another 40,000 on the 22nd. That's when our first batch of the Moderna comes in at 72,000 doses. Then we'll get another 50,000 on December 29th of Pfizer and another 32,000 of Moderna. So by the end of the year, we'll have quite a few. I mean, it's not enough for everybody, but I'm hoping to be one of those.
So who are those? Who is getting that? So what population are you talking about?
As far as what? What do you mean?
In other words, you said about, what was that, 80 to 100,000
so
vaccines?
That's Group 1A. So that's frontline healthcare workers, long-term nursing care, home staff people,
right?
First responders. And I think the way there was a program set up, and forgive, I don't know the name of it, but basically it gave all the licensed skilled nursing facilities had a chance to opt in for getting a sort of a cut of those initial doses for their residents. And apparently every single skilled nursing home in the state applied and was approved for that. So we have 100% coverage of the residents in the nursing homes, of the people that will be able to get that. So that's pretty cool. And then we'll see what happens after that. I don't know.
That number is for 1A in the state.
Yeah.
Okay.
Yeah.
Very good.
Hey, it's funny. So it's funny you say that, because in Florida, and maybe the same in Texas and in Oregon, but all the ALFs were told that CVS and Walgreens were going to take care of all of their vaccinations.
Oh, wow.
So they all got a call from the CVS and Walgreens. They got signed up. And I remember, have CVS and Walgreens ever done any kind of outreach, hired people to go out? No, they have not done that. So we just heard today that the state of Florida, and this is kind of information is probably not about a lot to be let out, but the state of Florida basically said, CVS and Walgreens are not ready to do this. Well, duh, right? I mean, did you ever think that they'd be ready to do this? No, they're not ready. So now they're sending in 11,000 doses, and now they're trying to scramble to figure out how to get these ALFs those dosages. So
I have a question.
Yeah, go ahead.
They're going to ask EMS and fire to do it.
Right? That's right.
Because right. I mean, the state of Oregon. So we had a 136-page plan came out from the state, and EMS is in there about 58 times.
Well, the truth is, just like all of emergency medicine, we're going to bitch and moan, and you know what we're going to do?
Do it.
We're going to take care of the patients.
Yeah. We're going to get it done. Right.
Yeah.
So the one thing I'll say is that we polled our firefighter paramedics, and we're at 40% of them who want the vaccine. Now, this is before we've given them like the talk, if you will.
Yep.
Here's my prediction. Is that because like I have a twin brother. He sent me this meme today, and I think I sent it to you guys earlier. It was that meme about where was it? Hold on a second. That meme I sent you that, are you the only survivor on this planet? The alien asked the one human being. He says, yes, they forgot to vaccinate me. My brother sent me that. He said, hey, I heard that if you're a woman, you won't be able to have kids anymore. Like, this is my twin brother.
Yeah.
He's a stockbroker. Here's my prediction. I predict that once the vaccine starts, there you go. That's it.
I was trying to see if it would focus, but
yeah, that works, Mike.
As soon as the vaccine comes out, within a couple of months, people are going to start to see that this thing is actually good. It works. very few side effects. And then there's going to be, I think in like February, a massive amount of people who were like able to get the vaccine in January who said, nah, you know, pregnancy issues, whatever. And then they're going to come and say, oh, vaccinate me. We're going to say, sorry, you go back in with them.
Yep.
So 1,000%, this thing is going to be proven to be the future of vaccinations. These flu type vaccines that AstraZeneca made are crap.
Yeah.
50-60% accuracy, a lot of side effects. So for all the people who are listening, you know, get the freaking vaccine.
I gotta jump in and give a quick promo.
Oh, here we go.
Thank you, Mike. That's what I was going to say.
So if all this hot vaccine talk has got you riled up, which I'm sure it might.
What are the legal aspects of this, Mike?
Well, so there's a couple things here, right? So you might have heard of this hot new podcast called The Standard of Care. I don't know. You might not have. Legal aspects of EMS. Another
awesome pod.
Yep. So I think episode 2 dropped yesterday, matter of fact. Anyway, we are going to be teaming up and doing like this crossover massive event. On the 14th, we are recording. It's going to be a pre-recorded piece, but it's going to be Dr. Sani, Dr. Jarvis, myself, and a doctor from OHSU he's a resident, and we are going to be talking all about mRNA vaccines, everything you want to know about vaccines. And then on the heels of that, Standard of Care has got episode 3 queued up and ready to go, and that is the legal aspects of getting vaccines in the workplace. Can they make you do it? What's going on? Is there a case study? All that kind of stuff. So it will be the top binge-worthy series to catch for the month of December.
Well, funny you should mention binge-worthy. I will just close because I asked the question about whether you're going to get vaccinated. Mikey, you said, hell yeah. Peter, you said, bring it. I'm going to be at the front of the line. And what I'm going to do, so I'm not going to get intubated, vaccinated. I hope I'm not going to get intubated. I'm not going to get vaccinated with my first responders because I don't want to take it away from them. My hospital is going to vaccinate me. And yes, I'm going to be at the front of the line and I'm going to video it and I'm going to put it out all over social media. So there actually is, I saw a couple people talk about this. There actually is a campaign underway where medical directors, Dr. Kazan out in LA is a great example of this for the flu shot. We are all going to videotape ourselves and we're going to push this out because you mentioned the educational campaign. Right now, we're looking pretty good. Our EMS paramedics are at around 75% yes, 25 no. Our first responder firefighter colleagues are at 60-40. But that is before our educational campaign. And I'm really hoping that as we push this out, we show me getting it, our director getting it, our paramedics getting it. I'm hoping that it'll increase the uptake. So without talking more about vaccines, because I think I like the promo, let's close this out because shockingly, we have flapped our gums a little longer than we intended. What are the odds?
A little longer. Jeez, crap.
I have finally found some time to engage with Amazon Prime and Netflix again. Christy and I, my wife and I, have found a couple of truly binge-worthy shows, and I want to share them with you. And then I want to get your thoughts on your binge-worthy shows. Here are my number 3. And these are, by the way, to a T, highly inappropriate to watch with children. So just with that out of the way. Number 1, Fleabag on, I believe it's Amazon Prime. Really, really good show. The Marvelous Ms. Maisel, also incredibly good. And then The Umbrella Academy. Season 2 is so much better than season 1. Those are my 3. What do y'all got?
I know. I haven't heard of any of those shows.
Yeah,
oh my gosh. Peter, you will love them. If you're into highly inappropriate comedy.
He loves This Old House. He's a PABS guy.
Okay, Mike, you go and I'll save my This Old House for the end.
Okay, I just have one. The one thing we're watching right now, we've gone back in time, and I've absolutely enjoyed watching this with my wife. American Horror Story.
Good, interesting pick. American Horror Story. Not on my list, but
like,
if it worked for you.
It's like 10 seasons, 13 episodes each season. It's very interesting. They're all they're not connected, but they all use the same cast in different roles in each of the seasons. So it's been great.
That's good stuff.
Yeah. Hey, I wrote that down. All right. What about, you have two more, or are you just going to say the one?
No, pretty lame.
Okay. So I'm gonna mention a couple here. One is The Queen's Gambit. Have you guys seen that?
I've not watched it yet.
I haven't. I've heard great things. I hear Dane is pushing that one too.
Let me tell you what. I mean, my kids play chess. I'm not that smart to play. I'm a backgammon kind of guy, but it's chess and drugs. So it's like playing chess at Burning Man. Okay, this is what it is. Actually, it's wicked. It's a great show. The Undoing is what, and Wentworth. My wife loves those two shows.
Yeah, that's okay. So I lied. We got The Undoing, and there's another one. I think it's called Little Lies, Pretty something or other. That is also one that we've been watching, but we're waiting for the next seasons to come out.
Yeah, and then of course This Old House. So there you go.
All right, there we go.
All right, well, let me get us out of here. We have not set a record, but it's been a long one. Hey, listen, on behalf of Dr. Peter Antevy, Dr. Jeff Jarvis, Mike Verkest, you've been watching episode 38 of the EMS Lighthouse Project podcast, proud member of the Flight Bridge Ed Podcast Network, and, of course, a Fire Dog production.
Hey, Fire Dog production.
We will see you guys on the next one. We got a lot of stuff. We got at least 2 or 3 more lives in December, so keep an eye out for those. We'll get the technical issues figured out, and we'll just catch you on the next one. All right. Good night, you guys.
Thanks for having me, guys. Appreciate it.
Thank you so much for joining us. Really appreciated having you with us. As always, look forward to seeing you in person when we can actually do these things again.
And Jeff, I actually look forward to seeing you on December 15th on the Refresh 2021 free NCCR refresher. You're going to be on it, baby.
Yes, and thank you so much. I cannot believe we are about to get out of here without that plug. Peter, tell us all about it. So sorry, Mikey.
Nope.
No, so listen, the Hilton Head EMS chief, battalion chief, Tom Bouthillet, who's a great guy, big social media guy, came up with an idea. He's like, COVID's been such a shitty year. He called me up. He's like, hey, I'm thinking of this, of just putting out a free refresher. And he rallied the troops, and he got all these people involved, and Jeff is one of those people. And basically, there's 30 hours of free education, so you can go get recertified. Prodigy EMS, a great LMS system, who put it on for free. Red Flash is doing it for free. And so basically, if I would send that out to all of your medics at all your departments, and let's leave 2021 and enter 20. I mean, I'm gonna party like like I was 21 again in 2021, basically.
Jeez.
So can't wait to see you guys in person again.
Yeah. Awesome. Guys, for everybody out there listening to us, thank you for switching over to YouTube with us. And most importantly, thank you for what you do. It really makes a difference. Take care, guys.